Hello everyone, very good evening to all of you and welcome to the class. So today I am going to discuss about most important topics in the pathology. So these are the MCQs, but here I would like to tell you all the students that these topics are very important, so don't limit yourself till the questions only. So try to read these topics from my notes also, who have attended my lecture or who have used my app. So that will be the most effective method, right? So these topics are just for the sake of revision, so that you should be in touch and momentum of the pathology should be going on. So I hope I am visible and audible to all of you. Yash, I'm fine. How are you, Yash? I think I'm audible and visible. So let's start the question. So I will be putting question in front of you, and then I will be giving you a time of say 30 seconds to 1 minute, and then you have to give me the reply. Those who are giving me the correct answer first, I will take their name also, and then we will be discussing about that question also. Right? So let's start without any delay. Very good evening, Infinity Platter. So this is the question number one. True about metaplasia. True about metaplasia is, so what should be the right answer? Involves only epithelial cell, irreversible, occurs at stem cell, or occurs at mature cell level. So what should be the correct answer? So what should be correct answer for this question? Happy New Year, Happy New Year. Right, so okay. So here in this question, first correct answer I had got it from Infinity Player and Navya Rekha. Right? So what is true about metaplasia? See, what is metaplasia? So we all know that, right? If you have a little bit knowledge about this metaplasia, so we all know that metaplasia is a cellular adaptation, right? So this is very important to understand ki what is metaplasia. So metaplasia, if I say that, what is metaplasia? So metaplasia is an example of cellular adaptation, right? So it is an example of cellular adaptation, and all the cellular adaptations are reversible or irreversible. Reversible or irreversible. All the cellular adaptations are completely reversible. This is very, very important point, right? So this will be a completely reversible process, right? So that is what we have to remember, that this metaplasia is reversible, right? So this B option is not correct answer, right? So now you understood why I'm saying, because metaplasia is a completely reversible condition, and this is an example of cellular adaptation. Now the first option which is written involves only epithelial cell. So how many of you think that it involves only epithelial cell? How many of you feel that only epithelial cell will be involved? So what we need to understand, metaplasia, it is not only epithelial cell, it is of two types, right? So here we have to understand metaplasia is of two types. It can be epithelial also, it can be mesenchymal or connective tissue also. So that is very important, right? So that's why I said this first statement is also a wrong statement, because it is not only epithelial cell, it will be involving connective tissue also or mesenchymal cell also. So that is why we will broadly classify metaplasia into two types, epithelial type and mesenchymal or connective tissue type. Which is more common? Epithelial type is more common, right? Epithelial type is more common, and their examples are Barrett's esophagus. So whatever we are studying in Barrett's esophagus or squamous metaplasia of the respiratory tract, these are examples of epithelial metaplasia. Mesenchymal metaplasia was a question in earlier in exam, that myositis ossificans. See what is this says? Myositis ossificans. What is happening here? Muscles are getting inflamed, right? So when there is a muscle trauma, muscles are getting inflamed, right? So myositis, muscles are getting inflamed, and then they will be converted or replaced by bones. So what are the bones? Another connective tissue. Muscles are one connective tissue, bone is another connective tissue. So what we are seeing, muscle is replaced by bones. So one type of connective tissue is replaced by another type of connective tissue. So that is why it is also called as connective tissue metaplasia, or also known as mesenchymal metaplasia. So now you understand. So metaplasia is epithelial, mesenchymal both, and myositis ossificans, which was a question in exam, is an example of connective tissue metaplasia. So this was the question in exam, right? So it is an example of connective tissue metaplasia, right? So this is example of connective tissue metaplasia. Myositis ossificans is example of connective tissue metaplasia. So that was the question in exam, right? Now coming to the third and fourth option. True about metaplasia is, now this third and fourth option, if you look at the language, occurs at stem cell level, occurs at mature cell level. So now you know what examiner is talking about. In both these option, examiners are asking, or examiner is asking about what is the mechanism of the metaplasia. So here he is not talking about the definition of the metaplasia. Now understand, examiner is talking about what is the mechanism of metaplasia, right? So what should be the mechanism? What should be the mechanism at mature cell level or stem cell level? Can you tell me in the comment box? Right. So this is a very shrewd MCQ or tricky question. So what we need to understand, it does not occur at the mature cell level. So please remember, mechanism is not mature cell level. Mature cell level, when we talk about, that will be the definition of the metaplasia, right? So this is very important to understand. Definition of metaplasia is at mature cell level, right? So definition of metaplasia is at mature cell level. So correct answer should be C. So it is stem cell level, right? So please remember, mechanism is at stem cell level. So whenever examiner talk about mechanism, it will be at stem cell level. So now we will see what is the important point to remember here, right? Metaplasia, when we talk about definition, as I said, definition is at mature cell level. So now you can see that what I'm saying, mature cell, one type of mature cell replaced by another type of mature cell. Now understand. So when we talk about mature cell, then we will be talking about definition of the metaplasia, right? So mature cell replaced by another type of mature cell. So this will be definition of the metaplasia. So this is very important to notice what examiner is talking about. If he is talking about definition or simply what is metaplasia, so that is definition. But occurs at, it means examiner is talking about mechanism, and mechanism of metaplasia is stem cell reprogramming. So this is the right answer. Stem cell reprogramming is the mechanism of the metaplasia. No, occurs at, see the Nairobi, I will tell you here. See, this question is occurs at. So it means examiner is talking about what is the root level, means what is the mechanism of that thing, right? So this is important to remember that. Examiner is talking about mechanism of the metaplasia. He is not talking about the definition of the metaplasia. Occurs at means what is the basic thing, right, where it is happening. So basically it is happening at the level of root stem cells, right? And stem cells, they are reprogramming themselves, and then they are forming the different kind of mature cell, right? So now understand. So about metaplasia, I again revise. What is important? It is both epithelial and mesenchymal. It is completely reversible because they are cellular adaptations, and mechanism, it at stem cell. Definition will be one mature cell replaced by another type of mature cell, right? Now coming to the next question. Which of the following is true regarding given agarose gel electrophoresis plate? So now you can see A and B. There are two agarose gel electrophoresis plates, and examiner is talking about which is true about this one. Very good. So I can see, very nice. Very good. Very good. Thank you, Ashish. Very good. So in this question, Kastub, Sai Kiran, Nairobi, and Infinity Player. So these are students who have given me the first quick response for the correct answer. So that is a B, right? So what is the correct answer? Correct answer is B. So this A is for apoptosis and B is for necrosis, right? So that is why this B is the correct answer, right? So now I will give you explanation what is happening here, right? So actually if you look at this question, right, so basically it is belonging to the apoptosis, and in apoptosis, what is hallmark of apoptosis? So remember, this caspase activation is hallmark of apoptosis. So hallmark of apoptosis is caspase activation. So once caspase will be activated, what they will do? They will activate endonuclease. What endonuclease will do? They will cause chromatin clumping. So please remember what will happen in this chromatin clumping. Actually, this endonuclease is going to cause damage to the DNA, right? So try to understand what I'm saying. This endonuclease, as you can see, the name itself is telling it is going to cause DNA damage. But this DNA damage is not a random damage. Please remember what I'm talking about. Right now I am talking about apoptosis, right? Because I said this is a mechanism of apoptosis. So during apoptosis, what will happen? This caspase will be activated, and this activated caspase will activate endonuclease. Endonuclease will be causing DNA damage. But remember, this DNA damage in apoptosis will be a specific fragment. What is the meaning of a specific fragment? They will be always into the multiples of 180 to 200 base pair. So they will be always into the multiple of 180 to 200 base pair. So what will happen? This 180 to 200 base pair means they will be always into the multiples of 200. It will be 200, 400, 600, like that. So it will not be random that sometime 50, 100, it's not like that. It will be always into the multiples of 200, 400, 600, like that. So this type of multiple or specific fragment is called as internucleosomal DNA damage. And this was a question in AIIMS and NEETPG both exam, right? So internucleosomal DNA damage is seen in apoptosis, right? So that was the question in exam. Internucleosomal DNA damage is seen in apoptosis. So that is how a question had been asked in exam. So what is the meaning of internucleosomal DNA damage? They will be always into the multiples of 180 to 200 base pair. So that is how chromatin clumping will be happening, and this we are going to see on the agarose gel electrophoresis, right? So on agarose gel electrophoresis, when we are seeing like this, see, you can see there are two images, number 1 and number 2, right? In number 1, if you look at them, I am showing you, suppose it is a 200, 400, right? Look at them. The smaller one is 200, then there is a 400, then there is a 600, 800. So it is like a step ladder pattern, right? So this pattern is described as a step ladder pattern. So a step ladder pattern, see, now you have to be very you have to be very observant about the language of the question. If examiner is saying it is seen in, it means examiner is talking about both apoptosis and necrosis, because it is seen in necrosis also. So otherwise I would like to say like this step ladder pattern which is seen in apoptosis is not diagnostic. It is not diagnostic of the apoptosis, right? So what is this? It is characteristic. It is not diagnostic but characteristic, right? So this point we have to remember. It is not diagnostic but it is characteristic. This is the point we have to remember. In apoptosis it is characteristic, right? That is why it is not diagnostic, because it is seen in necrosis also. So that is what we have to pay attention in our exam time. What language examiner is using? If examiner is saying it is seen in, so answer will be both. If examiner says characteristic of, answer will be only apoptosis. Is it clear to all of you? Is it clear to all of you? If examiner says step ladder pattern is seen in, answer will be both, because it is seen in both, but it is not diagnostic of apoptosis, right? So that is why we will say that it is characteristic of apoptosis. If examiner uses the language characteristic, it will be apoptosis, right? Endonuclease, and who is doing this damage? So this step ladder pattern damage is because of which enzyme? It is because of endonuclease. So endonuclease is causing this step ladder pattern. So sometime examiner asked this kind of MCQ also. This was the older question also in exam, right? So endonuclease is responsible for step ladder pattern. Same endonuclease is responsible for this diffuse smearing pattern, because here it is a random damage, right? Here it is a random damage, and diffuse smearing pattern was also question in the AIIMS exam 2016, right? And this will be seen in necrosis. So that was the answer in exam, right? So diffuse necrosis pattern will be seen in which condition? It will be seen in necrosis. So that is the point we have to keep in mind, right? Now you can see this picture again I am showing you. So here you can observe these are the base pairs, right? So you can notice these are the base pairs which are getting increased. So all these are step ladder pattern, right? So a step ladder pattern is characteristic of apoptosis, and it is not diagnostic because it will be seen in necrosis. So what we are going to see in necrosis? In necrosis, we are going to see a smearing pattern, right? So these are the pictures of the robins which examiner will be asking you in exam, right? So now you understood this point. Step ladder pattern, apoptosis, necrosis both, but it is characteristic of apoptosis. A smearing pattern, it will be seen in necrosis, right? Now come to the next question. Next question, in cyclooxygenase pathway, which of the following helps in neutrophilic chemotaxis? Now you tell me answer for this question. Here I will again say that for this question, Prashant Yash Jangid has given me the first correct answer. Prashant and Yash Jangid has given me the first correct answer. See, many of you have got confused, or you can say you are biased. Why I'm saying, because you have already solved the questions where you have learned that neutrophilic chemotaxis is done by leukotriene B4, right? So these are the two things you have observed. Don't worry. You have committed mistake here, but you will never commit this mistake in your exam. This was the question in NEET and DNB both exams, right? Now, probably you have not read the language of the question carefully, because in the language you can see what is the question, which pathway I am talking about. Did you notice which pathway I am talking about? Which pathway? Cyclooxygenase pathway, right? Right? And all these lipoxin, leukotrienes and leukotriene B4 and C4. Can you tell me which pathway they belongs to? Can you tell me which pathway they belongs to? Cyclooxygenase or lipooxygenase? So these are lipooxygenases. So now you understand. So already it is ruled out. Now understand, it's not leukotriene B4, because examiner is talking about cyclooxygenase pathway. So what should be the answer? Answer should be PGF2 alpha. This is the cyclooxygenase COX pathway, right? This is the lipooxygenase LOX pathway, right? So this point we have to keep in mind, right? So this is how examiner will try to twist the question. You have to be very careful during exam time. Each and every word, each and every alphabet you have to study very carefully. This is how examiner will change the shaft of the question, and that cyclooxygenase pathway is the answer deciding word here, because many students, they will be getting biased for leukotriene B4. Immediately they will go for leukotriene B4, and that is how we have to avoid. So exam time, read question carefully, read all the options carefully. Sometime by reading options and opening your mind without getting biased, you will come to answer. Even if you are not knowing PGF2 alpha is for chemotaxis or not, you can easily know that rest of the three options are lipooxygenase pathway. So fourth one is ruled out, right? So now answer, and you understand, the fourth one is ruled out. So fourth one is the right answer. So here I will just again refresh your mind that if you look at the lipooxygenase pathway, so there are two enzymes, 5-lipoxygenase and 12-lipoxygenase, right? So by 5-lipoxygenase pathway, 5-lipoxygenase pathway and 12-lipoxygenase pathway, what will be formed? So by 5-lipoxygenase pathway, we will see leukotriene A4, leukotriene B4, and leukotriene B4 is for chemotaxis of neutrophil, right? Leukotriene C4, D4 and E4 together, they are called as SRSA. So please remember, this is also one important MCQ. What is SRSA? It is a slow reacting substances for anaphylaxis, right? Slow reacting substances for anaphylaxis are these three things together: leukotriene C4, leukotriene D4, leukotriene E4. So all these three things together are called as slow reacting substances of anaphylaxis. So now you can notice one thing. Whatever I am showing you here, chemotaxis, anaphylaxis, these are all for inflammation, right? These are all for inflammation. So we are seeing only inflammatory mediators in this pathway, right? So we are seeing inflammatory mediators in this pathway, right? But when you pay attention to the 12 lipooxygenase pathway, so here you are seeing the formation of lipoxin. That is another important MCQ in exam. So what is lipoxin? Lipoxin is another compound, but remember, this is not an inflammatory. This is anti-inflammatory compound, right? So lipoxin is anti-inflammatory compound, right? So lipoxin is anti-inflammatory compound, and what they will do, they will inhibit neutrophilic chemotaxis. They will inhibit neutrophilic chemotaxis, and they will also activate macrophages for phagocytosis of neutrophil, right? So that will be another important thing we have to remember. So now you understand what I'm saying. In lipooxygenase pathway, we are seeing two segments. One is 5 lipooxygenase, one is 12 lipooxygenase. So 5 is for inflammation. Now understand, 5 is for inflammation. They are doing all these things. And 12 lipooxygenase is anti-inflammatory. So that was the question in exam. So remember, this was the question in exam. Anti-inflammatory compound found by 12 lipooxygenase pathway. Answer is lipoxin, right? This is one question. Second question which examiner had asked, what is the function of lipoxin? So now you can see what is the function of lipoxin. These are the function of the lipoxin. Inhibit the neutrophil chemotaxis and activate the macrophage and monocyte for the phagocytosis of neutrophil. So basically you can see lipoxin का जो basic target है, basic target of lipoxin is to avoid inflammation, right? So they will prevent neutrophil, and if neutrophil is coming also, they will activate macrophage also to kill them, to remove them, so that inflammation should not happen. So that is why lipoxin is anti-inflammatory, right? And if you look at the cyclooxygenase pathway, this is again a very important question in exam. So one must remember that cyclooxygenase pathway, we have a two common substrates. Please remember, this was the question in PGI exam also. So prostaglandin G2 and prostaglandin H2. If I say that these two things are considered as common substrate, so we will always say that this is the common substrate. So in cyclooxygenase pathway, so why it is common substrate? Because from this common substrate, there will be production of the prostacyclin, thromboxane A2 and prostaglandins, right? So now here in this question we have discussed about the option was prostaglandin. So I will just briefly tell you about the prostaglandin, what will happen, right? So when we are seeing prostaglandin E2, this was the question in NEET exam so many times. So please remember, it's a very, very important. I'm putting 3 star to this because this is associated with which process? Pain and fever. So pain and fever is associated with prostaglandin E2 alpha, right? Prostaglandin E2 alpha and prostaglandin D2 alpha and F2 alpha. Prostaglandin D2 alpha and F2 alpha both are associated with neutrophilic chemotaxis, right? So they are associated with neutrophilic chemotaxis. So these are the important point. So now you understand, this was the question. Neutrophilic chemotaxis, who will do? It is PGD2 alpha also, PGF2 alpha also, right? What is the function of PGE2? PGE2 is associated with pain and fever. So these are earlier question in exam which examiner had asked, right, in NEETPG exam. Right, to now understand, so prostaglandin, they are derived from the common substrate which is prostaglandin G2 and prostaglandin H2, right? And PGF2 alpha, right? So I think I have covered all these things, right? So answer should be prostaglandin F2 alpha, right? So now you can see that I have written here also that if you look at them, PGE2 alpha is for pain and fever, D2 alpha and F2 alpha is associated with neutrophilic chemotaxis, right? So now next question is about genetics. Chromatin organization within nucleus is controlled by. This is again a very favorite question of the NEET PG people, and this question came twice in the NEET PG exam and once in the DNB exam. So tell me, what should be the right answer for this question? Chromatin organization is controlled by microRNA, the small interfering RNA, long non-coding RNA, or transposons. What should be right answer? Right. So chromatin organization, Infantry Platter and Prashant. These are the two students who have given me the first correct answer. Right. So it is D. Chromatin organization is done by transposons. So it's a straightforward question. Right. It's done by transposons. So here, I would like to ask you one question. What is transposon? What is transposon? So remember, transposons are also called as jumping genes, right? Because they are continuously migrating or jumping within our human genome. So that is why transposons are also called as jumping genes. And what are the transposons? Transposons are coding or non-coding. So remember, whatever I have written, microRNA, small interfering RNA, long non-coding RNA, these are all non-coding RNAs, non-coding genes, right? Means introns. So that's what I want to say, that all of them are introns only, right? So I'm just writing here, for here, jumping genes are also introns, or you can say that non-coding areas, right? So many times we remember them intron means inhibitor and we get confused. Remember, these are majority of our human genome. Introns, what I mean to say, that introns are majority of our human genome, and they do not code but they regulate our human genome. So what transposons does, so if you look at look at the cell, right? In a cell is a eosinophilic cytoplasm, and nucleus will be basophilic, right? So why nucleus is basophilic? Because of the DNA, and DNA is arranged in a granular fibrillar chromatin. So this granular and fibrillar chromatin, please remember this point, this is a very important concept. Granular and fibrillar chromatin, this is the arrangement, right? So this is the arrangement, granular and fibrillar chromatin. It is controlled by transposons, right? So now understand, so transposons actually controls this granular and fibrillar chromatin network or arrangement in our normal cell. So I'm talking about normal cell. So in a normal cell, granular fibrillar chromatin is controlled by jumping genes or transposons. So that is the right answer, right? Chromatin organization within the nucleus controlled by transposons, which is also called as jumping genes, right? MicroRNA is a non-coding RNA. MicroRNA and small interfering RNA both are same thing. The only difference is microRNA is present in our human body, they are in vivo, and a small interfering RNA which we have taken outside, which is in vitro, right? So what I mean to say, that microRNA is endogenous and and a small interfering RNA is exogenous, outside the body, right? And what is the long non-coding RNA? So this is again intronic area, and remember, all of them are associated with gene silencing, right? All of them are associated with gene silencing, right? And that gene silencing will be post-transcriptional, right? Post-transcriptional gene silencing, right? Post-transcriptional gene silencing will be done by microRNA. Here I would like to tell you one important point about long non-coding RNA, right? Long non-coding RNA, because this is a little bit unique, right? Long means they are having longer number of the nucleotide, means more than 200 nucleotides are present, and they are having two functions. So please remember, this is very important to understand. Long non-coding RNA is both gene silencing and gene activator, right? So they are gene silencing also, and they are gene activation also. So both work will be done by them, right? Gene silencing example will be formation of the bar bodies, right? So bar bodies formation is example of gene silencing, and gene activation example will be stabilization of the protein structure. Stabilization of the protein structures, that tertiary or quaternary structure is stabilized. So that is done by long non-coding RNA, right? So this point we have to keep in mind, because long non-coding RNA resembles like a non-coding RNA, other non-coding RNA. But what is important in this, gene silencing and gene activation, both will be done by long non-coding RNA, right? So that is the important point to remember here, right? So now you understood this question also. Chromatin organization within the nucleus controlled by transposons, which is a jumping gene, which is a non-coding area, right? And that maintains the granular and fibrillar chromatin pattern in our cell, right? Now coming to the next question, it's the immunology question. Regulatory T cell, which had been asked in AIMS exam also, and NEET exam also, and DNB exam also. So now you tell me what should be the right answer. Regulatory T cells will have which receptor? CD4, CD8, CD4 and FOXP3, or all these things? Pi RNA is the most abundant RNA, infinity platter for you, I'm telling. Pi RNA is most abundant and they inhibit transposons. Pi RNA, they inhibit transposons. They inhibit transposons and they help in spermatogenesis also. So here I'm just coming back because one question was there. So I would like to tell you here that if examiner asks you what is the function of pi RNA, one of the very important function, they will inhibit the transposon, and second important function of the pi RNA, they are associated with spermatogenesis. That is very important, right? So do you understand? This pi RNA is having two functions. They inhibit transposons and they help in spermatogenesis. Right, now coming to this question, regulatory T cells, right? Regulatory T cells, again I will say here, very good. First correct answer is given by Nairobi and Prashant and and Namita. Right, Namita. So these are the some of the students who have given me the first correct answer. So here I will tell you about regulatory T cells. It's an example of helper T cells, right? It's an example of helper T cells which has been modified. When they will be modified? In the peripheral, right? In the peripheral they will be modified. And in peripheral blood, why they will be modified? Because of exposure to the self antigen. So now understand. So regulatory T cells are basically present in peripheral blood and they will be modified by exposure to the self antigen. So now I'm going to discuss that thing, right? So regulatory T cells, how you will show them? CD4T reg. So this is how it will be shown in the exam also, right? So reg word will be written, it means it is a regulatory T cells. So what is regulatory T cells? Actually these are helper T cells which are CD4T helper cells, right? So now you can see that helper T cell which is found in peripheral blood, actually it is a CD4T helper cells, right? So this CD4T helper cells, when they will reach into the peripheral blood or in the peripheral blood, when they are in the peripheral blood, right, and they are exposed to the, when they are exposed or stimulated by self antigen exposure, they will be converted into the regulatory T cells, right? And what is regulatory T cells? As I have told you, regulatory T cells will be now shown by another symbol, CD4T reg, right? So that is how we are going to identify regulatory T cells and differentiate it from the normal helper T cell. So what is the extra, means how we are going to differentiate the regulatory T cells, right? So here we have to understand, in regulatory T cells there will be only one receptor, that is CD4 receptors, whereas in case of CD4T regulatory T cells, CD4 is there, right? Because they are derived from the helper T cells, right? But along with this, there will be two more receptor on their surface, which is FOXP3 and CD25, right? So now I understand. So what is the regulatory cells? Regulatory T cells, they will have receptors CD4, FOXP3 and CD25. So all three will be present, right? So now see what is the use of this regulatory T cells, where as I have shown you, CD4 has been converted and now they are having CD4 receptor and CD25 and FOXP3. So why these two extra receptors are required on this regulatory T cells? Right. So what is the use of this thing? Because CD25 and FOXP3 genes, now they are going to help in synthesis of anti-inflammatory cytokine, right? Anti-inflammatory cytokine, who are the anti-inflammatory cytokines? So this IL-4, IL-10, TGF-beta, some of the names of the anti-inflammatory cytokine, right? So these are the anti-inflammatory cytokines which are synthesized by regulatory T cells, right? So what they will do? This anti-inflammatory cytokine will inhibit, right? What they will do? They will inhibit the proliferation and differentiation of autoreactive cells, right? So they will inhibit the proliferation and differentiation of autoreactive cells. So what will happen? Because of that, what will happen? If they are inhibiting autoreactive cells, so obviously this will prevent autoimmunity, right? So that is why we are not getting any autoimmune disorder. So there is no autoimmune disorder because of the regulatory T cells. So now you understand what is the significance of these two receptors, CD25 and FOXP3. They will synthesize anti-inflammatory cytokines, right? And these anti-inflammatory cytokine will inhibit proliferation and differentiation of any autoreactive cells, and as a result there will be no autoimmunity. So what I can say that regulatory T cells are associated with prevention of autoimmunity, right? Prevention of autoimmunity, and where? In the peripheral blood, right? And that is why when there is a mutation in the CD25 gene, this will be giving rise to a very famous neurological disorder called as multiple sclerosis, right? So this will be giving rise to multiple sclerosis. And if there is a defect in FOXP3, if there is a mutation in FOXP3, so this will be giving you another disorder which is called as IPEX syndrome. So just this much is enough for this discussion, right? So now understood on regulatory T cells, what are the receptors we will see? CD4, CD25 and FOXP3. So that is how it differs from the helper T cells, right? Right? So now understand. So what should be right answer for this question? Regulatory T cells will have CD4 also, they will be having CD4 receptor also, FOXP3 also, and CD25 also. So these receptors will be present. So correct answer will be D. So in exam time you have to be very, very watchful till the last option. So this is the correct answer, right? So CD4 is present, but CD4 is present in helper T cell also. So this does not differentiate them from regulatory. So what the best answer? Best answer should be the three receptors, right? CD4, FOXP3 and CD25, right? Now coming to the next question. Which of the following is true about this renal biopsy of diabetes mellitus patient? Right? Which of the following is true? So now you have to see, I will just write it down because it is not written. This is the Congo red staining, right, on light microscopy, and this is the Congo red staining with polarized microscopy. So there are two pictures I have given you. Number one, which is the staining with the light microscopy. This is Congo red staining with the number two with polarized microscopy. So now by seeing this, we have to understand what I have shown you in this picture by knowing the name of stains and the microscopy. And now let me find out the correct answer from you people. Right. Fine. So I think I have seen Prashant, Infinity Platter, and Pooja there. These are the some of the students who have given me the quickest answer. So great. Those who are not able to give right answer, please don't worry. If you have not given right answer here, so you are going to remember this in your exam also, and you are not going to commit mistakes. So this is a one good thing. So don't get frustrated that I'm not giving any correct answer. It's not a competition that you should give correct answer. It is the competition to improve ourselves. If you are committing mistake, we should know that what mistake I have committed, how I am going to improve upon it. And once you will understand, once you will start analyzing yourself, you will never commit the same mistake in your exam. So whatever mistake you are committing here, you are not going to repeat it in your exam, right? So see what I have shown you here in this question. This is the renal biopsy, number one, right, from a diabetes patient. So if it is a renal biopsy, diabetes patient, and I am showing you Congo red staining, so what is this? Can you tell me in the comment box which disorder I am talking about in this question? I am talking about amyloidosis of which organ? Kidney, right? So amyloidosis of kidney. So I am talking about amyloidosis of kidney, right? So amyloidosis of kidney, can you tell me what is the most common presentation? Right? So in this amyloidosis kidney, what will be the most common presentation? Now understand. So this picture which I am showing you, this is the congruent staining light microscopy. This is the congruent staining polarized microscopy. And question is mentioning renal biopsy diabetes. So probably it is a amyloidosis because congruent staining. So amyloidosis is present, and this is amyloidosis of the kidney. So what is most common presentation of the amyloidosis of the kidney? Hypertension or nephrotic syndrome? Hypertension or nephrotic syndrome? Tell me. We will go stepwise. So most common presentation is nephrotic syndrome or massive proteinuria, right? So please remember, most common presentation of amyloidosis of the kidney is massive proteinuria, or which is also called as nephrotic syndrome. So it is more commoner than hypertension. So hypertension is not most common. So now you can see what is the language of this question. Language of the question is hypertension is most common presentation in these patients. So hypertension is not most common. What is most common? What is most common? It is nephrotic syndrome which is most common. So this is the wrong statement. So first option is ruled out. Now coming to the second option. A beta 2 microglobulin is all commonly seen in such patient. Will you find beta 2 microglobulin commonly in such patient? Diabetic patient, amyloidosis patient. So beta 2 microglobulin, where you will see commonly? This is commonly seen in which condition? It is seen mostly in hemodialysis, right? It is seen in hemodialysis associated amyloidosis, and it is a diabetes mellitus. So it is not the beta 2 microglobulin which will be seen here. So which will be seen here then? So this B option is also wrong, right? So in diabetes mellitus, which type of amyloidosis we are going to see? Can you tell me? Diabetes mellitus, which kind of amyloidosis we can see? So that will be amyloid associated polypeptide, AIPP. Now understand? Amyloid associated polypeptide, right? So amyloid associated islet cell associated polypeptide will be there, right? So that is what we have to remember, right? So where we will see them? So now first option and second option has been ruled out because beta 2 microglobulin is seen in hemodialysis. Now understand this point. Beta 2 microglobulin is seen in hemodialysis. So it is not hemodialysis, it is a diabetes mellitus. In diabetes mellitus, we are seeing islet cell associated polypeptide amyloidosis, right? So which will be seen in type 2 diabetes, not in type 1 diabetes. So that is the important point, right? So type 1 diabetes, we will not see amyloidosis. So correct answer will be D. In type 2 diabetes only you will see amyloidosis, right? A, amyloidosis, and I is islet cell associated polypeptide, right? So this protein will be getting deposited into the islet cell associated polypeptide will be present in this type 2 diabetes. This type 1 diabetes you are not going to see, right? So now you can see that I'm going to explain this congruent staining also, because sometime so answer is D. So we all know that. Now I want to give a brief on the congruent staining, because this question had been asked in exam also, right? Regarding congruent staining, we have to be very careful where we are going to use congruent staining, right? What examiner is saying. If examiner says, please remember, if examiner says it is a ordinary light, please try to understand, ordinary light or polarized light, right? Both are different thing. When examiner uses word ordinary light, it means he is talking about light microscopy. When examiner is talking about polarized light, it means he is talking about polarized microscopy, right? On light microscopic examination or under ordinary light, congruent staining, we will see amyloid. Amyloid as a red pink color, right? And this red pink color is non-diagnostic. So why it is non-diagnostic? Under ordinary light, we are going to see red pink color of amyloid with congruent staining. So why it is non-diagnostic? Because these are the differential diagnosis. Amyloid, it can be hyaline, it can be fibrin, it can be collagen. So all can be extracellular, acellular, pink amorphous material. So that is why light microscopy congruent staining is non-diagnostic, right? So it is non-diagnostic because it can be amyloid also, it can be hyaline also, it can be fibrin also, it can be collagen also. So what we will do? So now we are going to see the second method. We are going to apply the polarized microscopy with polarized light, and in polarized light we will see apple green birefringence. So that second diagram was apple green birefringence, and this will be diagnostic of amyloidosis, right? So that is what we have to remember. This will be diagnostic of amyloidosis. So that is how you have to understand. So now again I am showing you, this is the congruent staining, right? So in this congruent staining, it's not Kimmel steel lesion, right? So whatever you are seeing here, these are all acellular pink amorphous material, right? So this is a acellular pink amorphous material. This is congruent staining, right? So how I am going to describe this? Pink amorphous, because there is no morphology. Amorphous means no morphology. Morphous means morphology. Amorphous means no morphology, and color is pink, and they are acellular, right? There are no cells seen here, and they are also extracellular. So pink amorphous acellular extracellular material on congruent staining, light microscopy. This can be amyloid also, as I have said. This can be hyaline also, this can be fibrin also, this can be collagen also. So that is why this is non-diagnostic, right? So we cannot diagnose amyloidosis by simply seeing the light microscopy. Now I understand, simply seeing the light microscopy is not diagnostic in the congruent staining. So what we have to do, we have to look them under the congruent staining, apple green birefringence, right? So now when we are seeing them under polarized light, now you can see under polarized light, you can notice all these are apple green. So you can see apple green birefringence. So this apple green birefringence, when you see on polarized microscopy with polarized light, this will be diagnostic of amyloidosis. So that is how we will see that. So diagnostic of amyloidosis, this is the apple green birefringence. Is it clear to all of you? So be careful during exam time what examiner is talking about. Congruent staining, light microscopy, non-diagnostic. Congruent staining with polarized microscopy and this kind of apple green birefringence, that will confirm the diagnosis of amyloidosis, right? So I hope this is clear. Yeah, we will revise in the next time. I will be framing the question paper. I will coming with the different type of amyloidosis. Nairobi, don't worry. I am making all these notes right for the next class, right? Now coming to the last question of the session, the 5-hydroxy-indole acetic acid, which was a NEETPG question also, in urine is suggestive of which cancer? So tell me, what is this? This is the tumor marker, right? So one of the very important topic I will tell you, whenever you are going for your exam, you must revise tumor marker from my notes. You will definitely get question in your exam. 1 or 2 question will definitely in your exam, right? Either it is a surgery question or medicine question or patho question, we cannot say, but you will definitely get a question from the tumor marker. So what is this? 5-hydroxy-indole acetic acid, medullary carcinoma, seminoma, choriocarcinoma, or carcinoid? What should be right answer? Very good. So Nairobi has given me the first correct answer. Nairobi, Prashant and Infinity Platter, and they have given me the first correct answer for this question also, right? So here we have to remember that 5-hydroxy-indole acetic acid, 5-hydroxy-indole acetic acid is a direct question. It is a tumor marker for the carcinoid. What is the tumor marker for the medullary carcinoma of thyroid? Can you tell me in the comment box? Medullary carcinoma of thyroid, what will be the tumor marker? What will be the tumor marker here? Medullary carcinoma of thyroid, tumor marker will be calcitonin, right? And for seminoma it is LDH, right? Placental alkaline phosphatase, and in certain cases even beta HCG can be also, in 15% of the cases, beta HCG. So please remember, for seminoma, this beta HCG is also a tumor marker for seminoma, right? And same beta HCG is also for choriocarcinoma. So for choriocarcinoma also beta HCG is a tumor marker. So these are the tumor markers. So correct answer for this question is carcinoid. So let's have a brief outline of some of the hormones. Actually these are hormonal tumor or endocrine tumors. So I would like to tell you these are important hormones which are the markers, right? So calcitonin, beta HCG, 5-HIA, and vanillyl mandelic acid. So these are 4 important hormones which are considered as a tumor marker. So these hormones I am talking about, they are actually a part of tumor markers. So now we are discussing about hormones, and these hormones are tumor markers. So this is the tumor marker. So what are the tumor marker? So as I said, this is the calcitonin, beta HCG, another hormone, 5-hydroxy-indole acetic acid, and vanillyl mandelic acid. Remember here, beta HCG is a tumor marker, but alpha HCG is not a tumor marker, right? So that point should be clear. So calcitonin is for medullary carcinoma of thyroid, as I have told you, right? Beta HCG is for both choriocarcinoma and seminoma. And what we need to remember, alpha HCG is not a tumor marker. So that is again important MCQ in exam, right? Sometimes they will be asking which is not a tumor marker. So that time you have to remember alpha HCG is not a tumor marker. So alpha HCG is not a tumor marker. So this alpha HCG will be alpha HCG. Why they are not tumor marker? Because alpha subunit resembles like LH, FSH and TSH, and they are most commonly resembling with, this was the INICET question previous year, they most commonly resemble with LH, right? So that is the important thing we have to remember. If examiner is asking to choose one answer, LH is the better answer, right? So otherwise alpha subunit resembles to the all the hormones LH, FSH and TSH. That is why it is not a tumor marker. So that is why it is not considered as a tumor marker. So it is not a tumor marker. This is very important. 5-hydroxy indole, which was the question in this MCQ, it is for carcinoid, right? And vanillyl mandelic acid, this was again a question in the NEET-PG exam. Vanillyl mandelic acid is a tumor marker for both neuroblastoma and pheochromocytoma. Pheochromocytoma is a term when they are involving or they are arising from the adrenal gland, and when they are arising from the extra-adrenal area, then this will be also written as a paraganglioma, right? So this is how we have to remember these 4 important hormones for the tumor, right? Dr. Sarcastic, steroid mechanism in immunosuppression, I think better to ask the pharmacology professor, that he will be explaining you, because there are different types of steroid and there are different type of actions, right? So better if you ask the pharmacology professor, he will be explaining, right? So these are all the questions. Here I would like to request you that please keep seeing all the playlist of the pathology live lecture, which I will be posting all these PDF, whatever lecture I have taken just now, I am going to post this PDF in my Telegram group, right? In my Telegram group, and just I will request you all, there is a playlist of pathology live lecture in my YouTube channel, so please do watch all of them, right? There are many lectures and there are many good lectures like a GIT polyp or cardiomyopathy, so please go through all those lectures, it will be helping you. As I said, I have my Telegram group. In my Telegram group, this is the link, right? And I'm going to post this link in the comment box also, and all these things, so you can see the PDF of this thing also, which will be posted after some time. So thank you so much guys, and happy new year to all of you. So again we will be coming soon, and we will be discussing like this, and I am noticing whatever topic you are telling in the chat box that I have to discuss. The next topic I am going to discuss is hematology. I think next topic we are going to discuss hematology. Tomorrow I will be coming with the hematology. So thank you so much to all of you. Keep revising your notes, and